My name is Sabina de Geest, and I have the honor to host this webinar in name of all my colleagues who belong to the Swiss Implantation Science Network Impact. Today, we have a very important colleague of the field of implantation and dissemination science who is joining us. She is currently in Switzerland, yet we are all connected by Zoom. And Dr. Enola Proctor is our webinar speaker of today. Most of you who already have read papers on implantation science have met the name of Dr. Proctor already several times. She's extremely influential in the field, and her research is motivated by the question, how do we ensure that people receive the best possible care? Dr. Proctor studied this question in a variety of fields like social work, public health, and also a number of healthcare settings, such as hospitals, to community agencies. You can really say that she has contributed to the intellectual capital for the rapidly growing field of dissemination and implementation science, and leading teams to distinguish, clearly define, develop taxonomies, and stimulate more systematic work to advance the conceptual, linguistic, and methodological clarity in the field. Dr. Proctor, her research has really been supported by the major funding agencies of the US, and this over 26 consecutive years, such as, for instance, the National Institutes of Health. She's directing the Implantation Research Institute, which is a training program in implantation science and which is funded by the National Institute for Mental Health. She led the establishment of several university-wide centers and cores in implantation science, including the Center for Dissemination and Implantation for the Washington University Institute for Public Health and the Dissemination Implementation Research Core for Washington University CTSA program. She has received numerous awards, and if you look on PubMed, and also on the publications that position implantation and dissemination scientists in the field, she is clearly a leading lady. So Dr. Proctor, it's fantastic you're in Switzerland. It's fantastic that we can benefit from your expertise, your insights. And today you will talk about FAST, a framework to assess speed of translation of health innovations to practice and policy. Dr. Proctor will start with her lecture, and we invite all that are part of this webinar to put their questions, remarks, reflections in the chat. After the lecture of Dr. Proctor, we will have time for exchange and discussion. And I think, Dr. Proctor, it's now really the time to give the word to you. Again, thank you so much for accepting our invitation. And honestly, this is for us a very special moment to give you the floor.
Thank you so very much for that wonderful introduction. And I'm extremely pleased to be here with you today. And Julianne, if you can run in, please. This has been a long time coming. I know we planned this visit prior to the COVID shutdown, and therefore we are really delighted that the time has finally come. So we're loading up my slides. Thank you very much. So I'm really pleased to talk with you about the FAST framework, which is a relatively new emphasis in my work. And I'll share with you some of the reasons that this has become, for me, a really important question. I am based at Washington University in St. Louis at the Brown School of Social Work. And as you heard, the Institute for Public Health and the Institute for Clinical and Translational Sciences. But I'm coming to you actually from Basel, Switzerland, which is a delightful place. Switzerland is one of my favorite countries to visit. This is my first visit to Basel, and it's charming. The weather is lovely, and I know many of you are joining from around the world. I hope you are having as lovely a springtime for those of you in the Northern Hemisphere, and a lovely start to fall for those of you in the Southern Hemisphere, as we are having here from Switzerland. So I think we all know that the focus of implementation science is to try to increase the use of new discoveries from research and to accelerate that, and simultaneously to decrease the use of ineffective, wasteful, or harmful interventions. But we're plagued by this notion that it takes a long time to implement new discoveries. Over 23 years ago, authors Ballas and Bourne calculated that it took 17 years for new breaking research knowledge to reach actual clinical care where it could be delivered and benefit people who use our services. And I've been plagued by wondering, does it really take 17 years? I've had potential organizational adopters ask me, if I start this now, is it going to take 17 years? We have a new, relatively new publication just about a year and a half ago. Kahn, Chambers, and Netta found that it does take still a very long time to implement new research developments in the space of cancer. They calculated that it's still taking about 15 years to implement new clinical guidelines for the care of cancer. But can we really live with 15 years or 17 years? We're all coming out of a pandemic where if we'd waited 15 or 17 years for our newly discovered interventions for COVID-19, we might not all still be here. Similarly with disaster relief, with the opioid crisis, when children are being maltreated, with rapidly progressing diseases such as Alzheimer's, older adults may not be living in 17 years, and we need to accelerate both for children and older adults the implementation and the availability of newly discovered care. Some disorders and diseases move fast, and time is of the essence. This is clearly the case in cancer, in bloodstream infections, and traumatic injuries. So I think we've learned from the real world that 17 years is too long, 15 years are too long, and we need to certainly figure out when and how we might accelerate the implementation of new treatments into settings of care where people can actually benefit from it. So the 17 years has kind of been our raison d'etre for implementation science. We need to shorten this, and we just lived through a global pandemic when we knew that certainly we needed to move faster. With COVID, we really needed to know what to do. And I've loved this photo from a journal in the US called Science that characterized it as medicine's longest year. We were desperate to know what to do. All of a sudden, my mouse is not advancing. There we go. So we needed to develop a vaccine fast, and amazingly, scientists did. We should not lose sight of the fact that the vaccine, while it was developed within 1 year and treatments were identified for COVID even prior to having a vaccine, that this built on decades of prior investment into mRNA mechanisms. How do we move fast with viruses in the body? How can we build vaccines that will work on mechanisms that we know, although we haven't really used them before? So clearly, the rapid development of vaccines for COVID built on many years of prior research. But we learned within a matter of weeks and months that COVID was airborne, and therefore wiping down surfaces was not as important as was masking and wearing personal protective equipment. We learned that quarantines were needed. We learned that we needed to actually shut down a lot of our interactions, our social interactions. But we ran into obstacles worldwide. Many people suspected the COVID vaccine, not because it was developed slowly, but because it seemed to be developed so fast. We had politicized environments in many parts of the world. We didn't have enough supplies. Our responses were not global, although the pandemic was global. Sometimes they were not even nationally accepted in some countries. We found that all of these factors resulted in inequitable distribution and inequitable access to things even like masks and personal protective gear, but certainly vaccines. And we also encountered a very pesky virus in that it was highly contagious and often asymptomatic. So while science moved fast to develop a vaccine, we encountered many obstacles that slowed our uptake of these new discoveries. And as a result, this virus was allowed to impose long-term morbidity. We're still trying to understand long COVID. We know that we're recently learning that even people with low viral load infections still suffer long-term morbidity. Clearly, our health systems were disrupted. We're still facing the consequences of delayed care. We're still not recovered from the economic impact. And we know that social isolation, in fact, you may have seen that in the US, the Surgeon General has drawn attention to loneliness and social isolation that persists after COVID. And we're still suffering the mental health effects of this virus. And yet we have data that the speed of our response really did matter. And I'm sharing here some findings of a project or a research study led by my colleague Elvin Ging at Washington University, where he studied within the state of Missouri how quickly different counties and regional units within our state adopted the policy suggestions that were needed to cope with COVID. And he found that slow really does matter and leads to increased hospitalization. If there was simply a 1-week delay in enacting the policy recommendations regarding isolation, closures, masking, it increased hospitalizations from 2,000, it increased them fourfold to 8,000 and increased death, 3 times the number of deaths for regional units that delayed these policy implementation by 1 week. If we look at a 2-week delay, we saw almost a 600% increase in deaths. So clearly, speed mattered. Speed mattered, although we still moved at a relatively slow pace. I think the question we're now facing, we have reason to believe that there will be future pandemics. We know that there are environmentally triggered disasters. We know that infections are widespread and can accelerate. So the question is, what did we learn from COVID? And are we equipped as a health field? Are we prepared as implementation scientists to ensure that we can do better the next time? Dr. Ging and I called for an explicit focus within implementation research on a lane of science that is focused on rapid uptake of proven interventions, because we quickly learned that knowing what to do does not ensure that we do what we know, nor does it mean that we will act quickly enough. So we have a lot to reflect on and a lot to learn. However, within our field of implementation science, speed, or the pace of adoption of new discoveries, is really understudied. And our current research approaches have not really accelerated implementation, although we certainly have some design innovations that I will refer to later, including hybrid effectiveness trials that are explicitly meant to help speed things. So we are really not very well equipped to answer the question, what are the factors that are most key to affecting the speed of implementation? Now, studying and knowing how to increase speed is really a complex challenge. What is fast enough? Do we sometimes move too fast? Do we know how to measure speed? And most importantly, can we identify the factors that are associated with faster or slower implementation? And I'll be sharing in this presentation some of the thinking that my team, including my primary colleague in this examination of speed, Alex Ramsey, with whom we've written 2 papers about speed. I'll be sharing what we thought about and what we propose in a recent paper called FAST, a framework to assess speed of translation of health innovations to policy and practice. So, what is the case for speed? Well, clearly I've identified several factors that mean we need to move fast. Health and social crises, the reactive nature of systems, organizations, national policies, these are slow to change by virtue of the system that we're talking about. And certainly, we have a lot of inequities, which means that disproportionately some groups continue to suffer, and it's simply unfair, unjust, until we can learn how to make implementation of evidence more equitable and ensure that better care reaches more people. However, there's also an argument for not moving too fast. Do we really want to move on implementation until we're confident that the interventions we want to implement are effective? So when we need more evidence, what do we do? Do we move ahead or do we wait for evidence? Certainly in the case of COVID, we tried a lot of mitigation strategies while the data were still developing. And COVID for me was the clearest example, an experiment in figuring out how do we move on the basis of emerging evidence. We also know that we need to engage stakeholders and engage community participants in particular. And moving toward implementation before we have key participants on board is sometimes unwise and sometimes backfires on us. We had many examples of that with regard to COVID. And we all are coming to appreciate the value of human-centered designs or user-centered designs. Do those take more time? Again, we really don't have evidence that engaging people and building innovations around their input through human-centered designs, we don't know how much extra time it takes, but we do have reason to believe that those are time-consuming processes. So, who cares about speed and why might they? In our paper FAST, we identified several different stakeholders and proposed what they might be thinking about speed. For intervention developers and trainers and purveyors, those who have discovered some effective intervention and want to get it out there in the real world, they really want to speed things up. And they may be asking, well, how long will this innovation be adopted so that its benefits can be realized? Clinicians may, on the other hand, think, if I'm going to start delivering something new, how long will it take me to learn that? How long until I feel competent? So they may be concerned about adopting a particular program that's going to take a long time for them to learn. The consumers of our health services are often eager for a new discovery. People who are suffering from life-threatening illnesses want to move fast, and they often experience a great deal of frustration while test results continue to come in until they can get an appointment. If there's a backlog, we're seeing in many systems of care, people having surgeries deferred because there are simply pressures on the healthcare service. So we often find that clients and patients are very impatient and they want to see things sped up. Administrators, on the other hand, might say, oh, how long am I going to be working at this? And if they've read our literature and have read that it may take 17 years, they may say from the outset, no, thank you. I don't have 17 years to invest in learning to deliver a new program in my agency. Policymakers wonder about speed. Again, how fast can we make this happen? Communities want to know when everybody's going to benefit from something, and advocates are often pressuring us to move faster, particularly around better quality of care or more equitable delivery of care. So there are several different sets of perspectives on speed, and they may be coming from different ideas about what matters. A main focus of our FAST paper was to ask, well, what are the influences on speed? And we came up with 4 categories and I'm going to unpack each of these and speak briefly about each of these. But first of all, the features of the innovation, that is the what that is being implemented. Second, adopter characteristics. We know from the granddaddy of all theories, Rogers' diffusion of innovation theories, that we have early adopters and we have this group that he called laggards, people who are slow to adopt almost anything. So he gifted us many years ago with the understanding that people vary in the speed with which they adopt new innovations. Some people are standing in line to buy the new iPhone before it's released, and other people are still using clunkier phones. So is there something in the adopter that affects the speed with which we want to take on something new? Certainly the features of context matter, the setting, the resources, and then our implementation strategies may differ in their complexity and therefore in the time required to enact them. So let's look a bit more closely at the features of the innovation. And these, again, come from some of Rogers' perspectives, that compatibility matters. And for the clinician who's asking, do I want to get trained in this new service delivery approach? Am I going to have to get retooled completely, or can I build upon the training that I already have? Am I partly there, or do I have to learn this new innovation from the start? We know that if we can demonstrate the relative advantage of something new, people are more eager to say, okay, I can see that it's going to be better, so I'll get on board with this. The complexity, how challenging is it? Is there payment available? And do we know that the innovation is the right one and actually is going to be more effective than our existing service delivery? Also, adopter characteristics that I referred to earlier. Are people open to risk? Are they open to change? Can they tolerate uncertainty? Can they tolerate the uncertainty that goes with adopting and delivering something new? And also capacity. Does an individual provider have the training, or are they willing to learn? Certainly the organizational context, the community context, the pull. Do users want the innovation? We saw this happening with the COVID vaccine. Did people want it? And where there was little pull for it, government entities, health systems had to try to increase the attractiveness or the perception of safety. We had to work at this, where some portions of our society, typically healthcare providers, were saying, yes, I want it. Give it to me now. I want to be in line. I know many of my friends and I were very eager to find the first vaccine that we could avail ourselves of. And certainly the context, is it an emergency? Do we see the urgency in adopting this new innovation? And is there a policy mandate? Are people saying you have to do it? Sometimes typically where there's a policy mandate, the speed of adoption will be fast. And then finally, implementation strategies. Training takes time, so that length of time required to use the implementation strategy is by definition going to influence the speed at which the new intervention becomes available and is delivered. Some implementation strategies are more straightforward. There may be an online training that is 2 or 3 hours or 1 week. On the other hand, the very effective implementation strategy of practice facilitation is multi-component. It involves task shifting, not only training, but coaching and monitoring. So using an implementation strategy that is multi-component and has sequential elements means that the adoption overall may be a bit slower. And then finally, there are simply some strategies that we believe do take time, such as identifying, training, and deploying trusted champions. Certainly co-developing strategies with communities requires meetings, requires that people give their time. We have to train healthcare professionals to address scientific mistrust or hesitancy. And then learning to tailor communication and outreach strategies to specific communities takes time, and it sometimes proceeds by trial and error. In St. Louis, we tried one strategy to get COVID vaccines out of deploying the National Guard. So there were a couple of Saturdays when large, massive clinics were set up, and when people drove up, they found people in military uniforms. And in communities with a very valid and historic distrust of medicine, because medicine and research have been used to experiment on them, there was not much uptake of getting a COVID shot from someone in a military unit. Well, we learned from that. And then we shifted to churches where physicians showed up after worship services and offered clinics that were endorsed by churches. That was a very different implementation strategy and had very different uptake. But sometimes we have to tailor our approach to different communities. And sometimes we only learn to tailor after we've had a bad or a first outing that proved not to be very fruitful. So if speed matters, and if we've learned a lot about the slow pace, how can we begin to accelerate implementation in areas and in contexts, in emergencies, when we know we do need to move faster? Well, we've had at in our repertoire of implementation research approaches, various hybrid trial designs. And hybrid 1 designs are really designed to help us capture knowledge about the context in intervention trials. So while we're testing the intervention, we can learn things about how acceptable is this? How much time does it take? What resources are required? What infrastructure needs to accompany this? And if, when we're doing a test of an intervention, testing its effectiveness, we can package that intervention trial as a hybrid 1 design and set out to capture and learn all that we can about what it takes to deliver it while we're testing its effectiveness. We can reap the benefits of that experience by noting, okay, it's not acceptable to all to whom it's offered. What are the acceptability challenges and what rates? And therefore, when we're going to move toward implementation, what do we need to do to work on acceptability? Similarly, we can learn about the time required to deliver an intervention when we're testing its effectiveness and the resources. And then we can bank those lessons. And when we're ready to launch implementation trials, we can know from the outset that these are some of the challenges that we have to address. What problems were encountered, what modifications could be made, and what potential implementation strategies can address those real-world barriers and bank on those facilitators that we learned about when we were testing the intervention. So again, how can the lessons learned affect speed? Well, it can tell us some of the work we need to do on the intervention at the organizational level and within the implementation context. A second recommendation that I have for accelerating speed is to build repertoires, accessible repertoires of implementation strategies. Now, I realize this is a recommendation that really doesn't have any legs. I can't point to any actual examples of this. We know we have available and accessible repertoires of evidence-based interventions. We can go to guidelines. We can go to registries of best practices. There are some go-to sources across our different service delivery settings, be it medical, be it behavioral health, be it addiction, be it child welfare, be it aging services. We know that there are go-to sites where we can find a repertoire of effective interventions or guidelines that we should use. I know of no such repertoire of implementation strategies. And for those of you who've built them, I can't wait to hear from you. For those of you who know of them, please share that with me. I know that a federal organization in the United States called SAMHSA had at one time a listing of implementation purveyors for various evidence-based practices. In other words, they listed the evidence-based practice in a repertoire of effective interventions, but they included in that information about who to contact for training. So that was a very important step toward enabling people who wanted to implement something to let them know, okay, here's how you might start. You can contact this training organization, or you can work with this group and they will offer consultation. But in terms of implementation strategy, I don't know of a repertoire where we can see which strategies worked where, in what context, and for what intervention. Where can we go to find lists of implementation strategies that work for multi-level interventions and that maybe work for multiple evidence-based interventions at one time? I believe, however, that when we develop these repertoires, we need to include enough detail that people who go to the repertoire can learn who does what, when, and how much, and directed at what adopters. So we need to include in the repertoires not just what strategies appeared to work and hopefully their effectiveness, but also we need to specify the strategy in terms of these 5 critical components. I can give you an example of an idea that my colleagues and I came up with around COVID. And this is an example of documenting implementation activities that supported churches as champions for vaccine uptake. And this is what it might look like. Okay. The name of the strategy was using churches instead of the National Guard, or instead of primary care, or instead of community clinics in parking lots. Many implementers found that relying on trusted messengers with pastors and faith-based leaders as champions and as giving endorsement, that seemed to work against a lot of vaccine hesitancy. So a strategy of engaging churches for vaccine promotion is something that we can learn a lot about. If various churches could, or various implementers, implementation projects could document when were these clinics set up and how long were they available? Who actually was involved? Did they, was it a provincial health department? Did they include congregational members? Did they include endorsements from government to, you trust your church, please go ask your questions to your faith-based leaders? We need specification of the actual actions, like how were pastors and faith-based leaders, how were they reached? What did actors do? What did implementers do to engage them, to educate them, to motivate them, to get their willingness to use their own platform to endorse and encourage the uptake of COVID vaccine? How many conversations did it take with the pastors to get them on board? How many messages did the pastors have to get? And did we have to include in this strategy approaches to equip faith-based leaders to talk about the vaccine, to give the message that there are no fetal cells in this vaccine, to motivate pastors to say so? And how did we help pastors incorporate key talking points about vaccine in their various messages, in their newsletters, in their billboards or their signs in front of the church, in sermons, in coffees of worshipers, to say, next week, a nurse is going to be here to give a vaccine. We encourage you to come. I will be there. In other words, we need a lot of detail. And if we could have documentation of this as an example of an implementation strategy, could that be useful in our next pandemic to say, okay, here's what we tried with COVID, here's what we learned, and here's what it looked like. Another example would be outreach. We could document the fidelity, the acceptability, the appropriateness. We could measure the actionability, the sustainability, and the equity of the uptake of these kinds of strategies. So again, what I'm wishing we could get to, and to my knowledge, we're not here yet, but if during COVID, we could build it fast, we were all learning by trial and error. And if there were a great place in the internet where successful implementation could be described and specified in kind of a user access, a crowdsourcing where other implementers, people who want to implement, could go to a repository and learn what other people had done and how successful that were. So this is one of my visions for the future that I think might help speed up implementation. It would provide a go-to source for information about potential strategies. It could actually serve as a roster of what was used previously. It could tell us what's involved in terms of who does what, how much, where it was, where the strategy was used, and information about how effective that strategy proved to be. In a related paper that we wrote about designs, research designs for speeding up implementation, we argued that without different research approaches to testing, then the implementation of evidence to practice will remain slow. And that researchers must consider implementation needs at the outset, not just what we want to implement, but what it takes to implement. And again, we can harvest these ideas from prior hybrid 1 trials while we are testing the effectiveness of interventions. And then finally, I think we can move a little faster, even where uncertainty is high, if we are very transparent that evidence evolves and is subject to frequent reevaluation. COVID again provided an illustration of how skeptics and critics pushed back when the message about combating COVID changed. In the United States, we were first told masking isn't necessary. We soon learned it was critical. Does that mean that the message that masking, what proved to be something that was, that we learned differently, did that mean that science was wrong? No, it meant that science is an evolving approach, that we build on what we learned, and that we change our minds and we change our message. Not only because we didn't know, but because we are constantly learning. So I so wished during COVID that the evolving set of mitigation approaches, the great advances in science were viewed positively, that we were learning, and that this would underscore our faith in science rather than being used as a basis for mistrust of science. Clearly, the politicized environment worldwide made that this lesson that we do have uncertainty, that science is evolving and is subject to reevaluation. We're still, I think, appreciating that lesson, or that's my optimistic point. I saw a recent article that said, one of the strengths of science is its self-correcting nature. And science does self-correct. I think that's a good thing, not a weakness. And I believe that the speed with which we move along as science advances knowledge, that we can increase it and have greater trust when we realize that I, for one, am glad that I know more today than I knew yesterday, and I'm very hopeful and fully expect that I'll learn more. I will know more tomorrow than what I know today. So I think part of what slowed implementation in the era of COVID was our own very self-correcting, giving different messages because it undermined confidence in science. So finally, I'll end my remarks talking about some of the challenges to research. Very few studies, this is something we discovered when we were doing our literature search for the FAST paper that was published last summer. Very few studies actually report speed. They don't, frameworks and conceptual models such as phased approaches to implementation rarely time those phases. They rarely document nor report how long an exploration phase might take, how long training might take? How long does it take to achieve specific outcomes? And until our research begins to measure that and report it, we really will not know much about how long it takes to implement. Similarly, what observation periods make sense? The Ballas and Boris classic article unpacked several different observation periods. Does it go from initial funding of a study to change in routine clinical care? Or does it go from publishing the first findings to changing real-world care? Does it go from guideline incorporation or dissemination of evidence in the issuance of guidelines? Or does it go from when an individual provider or health organization starts delivering? How do we measure speed? This is really an unexplored area and one that I think we need more thinking about and more reporting. And there are several examples of how we could measure speed. The time elapsed, for instance, to train to fidelity. How many months does it take to get 60% of providers delivering an intervention at 50% fidelity? We could establish such markers and begin to calculate those periods of time and report them. We could look at rate of progress, the percent increase in sites adoptions. How fast do different sites adopt something over a 6-month period? We could have a visual depiction of providers attaining. We could show graphs of fidelity or of adoption. We could ask how long it takes to adapt a treatment to certain client group or population subsections. How long does it take to shape a treatment so that it better fits the context or is more acceptable to adopters? We could certainly learn from reports of how long human-centered design processes take. How many months does it take to actually develop an intervention with stakeholder input? So we have a lot of remaining questions, and our purpose in the FAST paper was to elevate attention to the issue of speed. Are we moving fast enough? When do we move too fast? How long does it take? And if we move fast, will change be sustainable? I was intrigued by the Broadway actor Andre DeShields, who said, remarking on his own journey to being an acclaimed actor, well, the fastest way to get where you are going is slow. Is that true for implementation science? Is the fastest way to get where we want to go slow? Or do we sometimes need to not go slow and speed things up? If we move fast, can we still have an inclusive approach to our research? Can we still share power with those who are going to adopt and benefit from interventions? Does fast last? How fast is best? Maybe you know the Goldilocks story, where the bed and the porridge were not too much, not too little, but just right. Can we ask a Goldilocks question of implementation science? How do we move not too slow, not too fast, but just right in various situations? So clearly the goal is to learn from our implementation on the ground initiatives to incorporate speed metrics so that we can be transparent, so that we can report, so that we can learn how long it takes to do what, so that we will be better prepared for the next pandemic, for the next disaster, or just the rollout of important medical care as new knowledge develops. So I want to thank you very much for this opportunity to share my thinking, to share my own questions with you, and now hopefully to be stimulated by your questions and to learn from you and your observations about this topic. So I'll turn it back to you. Dr. DeBree, so that you can moderate the questions, and I will try to watch in chat. Okay, I see lots of activity in the chat. So much came in that I couldn't keep track of it while I was talking. So Sabina,
We will help you. And first of all, wholehearted thank you for this presentation, which highlights some really key elements that are part of our implantation science work. I think indeed speed, as you put forward, with the new framework, is something that is a concern to all of us. I would like to start with the discussion and invite Laura Sheeran to unmute herself. And she had a number of remarks. So Laura, could you unmute yourself and also introduce yourself so that we know where you are and what your background is? And then we can start the discussion.
Thank you so much, Doctor. That's really great. I enjoyed hearing this talk very much because ExpandNet as a global network have been working in the field of scaling up, and there's a very strong interplay between implementation science and scaling up. And so I've never gotten to hear Dr. Proctor speak before, so thank you so much. And you'll note that a lot of the chat that I contributed related to issues of political will that are very important in any scaling up and implementation process. And I was highlighting that while we are learning from each other, from the implementation, the trajectory of implementation science and the trajectory of scaling science, one of our goals in ExpandNet is to really try to bring those two fields closer together.
Yes.
I think we have a lot to learn from each other, and I really, that's one of my missions nowadays. And so that's why I came today. And I just want to thank Dr. Proctor so much for sharing all those insights. So please visit our website and make use of those tools that I was highlighting in the chat.
Yes.
Thank you, everybody.
Well, it's so nice to meet you. I am familiar with ExpandNet, and in work that we did for the World Health Organization, where we developed some videos about what an implementation science perspective can do, or can lessons learned from implementation science for vaccine uptake. We certainly relied on ExpandNet on some of the frameworks for scale up, and I agree very much with the point that there's very close correspondence, a lot of interface that can be beneficial. So I'm delighted to meet you. I'm so glad that you called in, and I couldn't agree with you more. And perhaps our work, our voices will converge, and we will learn more from each other, and the fields will learn more from both of our arenas of work.
Thank you so much, Doctor.
So I would like to give the word now to my esteemed colleague of University of Zurich, Lauren Clark. So Lauren, please unmute yourself, introduce yourself, and I think you have also a very important question to ask. And Lauren is part of the Impact Network. That's also important to mention.
Hello, thank you very much for this wonderful presentation. I really enjoyed it, and I think it's a really important message to be thinking more about speed in implementation. I appreciate that very much. So one question, one of the easiest ways that I see to really bring the attention of lots of researchers to the importance of thinking about speed would be, to release an update to your famous list of outcomes for us to also consider speed as an implementation outcome. What do you think?
Well, thank you for that. With colleagues, we are writing an update to the 2011 implementation outcomes paper. Actually, it is a scoping review of studies that kind of took off from the 2011 paper and have cited that paper and then reported evidence, be it qualitative or quantitative, about research on implementation outcomes. And we asked a similar question, which we're addressing in that paper, about equity. Should equity be an implementation outcome? And for now, we are still happy with speed and equity being priority outcomes, but in the 2009 and 2011 paper, we had labeled those as service system outcomes, where timeliness of care is an outcome. We believe that implementation outcomes are necessary precursors and can contribute to or signal challenges with subsequent timely delivery of care and equitable delivery of care. And let me give a couple of examples why right now we're thinking not of framing timeliness as an implementation outcome, but if you will, an outcome of implementation outcomes. So just a brief, for those of you who haven't read either paper, we posited 3 categories of outcomes. Certainly clinical outcomes, population health improvement. That's what we're all striving for. But there are also service system outcomes that are important, such as efficiency, patient-centered care, equity, safety. And we cast those, we didn't define them, but the US Institute of Medicine had frameworks which listed those kinds of outcomes as service system outcomes. And efficiency was one that I think does reflect timeliness. It reflects more. And your question certainly prompts me to, reconsider this. Again, I hope I know tomorrow more than I know today. The iterative nature of learning and of science. But I think that many implementation outcomes stand to affect speed or timeliness. For instance, if interventions are not acceptable, I believe that will slow their uptake. And I think we saw that in COVID. If interventions are cost prohibitive, that will slow their uptake and mean that service systems, health delivery platforms will not be as efficient and timely in getting care out there. So in many ways, I think that speed may not be an implementation outcome, but rather serve in 2 ways. First of all, it should be a metric of achieving implementation outcomes. How long does it take to reach acceptability? How long did different countries take to get a certain vaccine percentage, certain percentage of the population vaccinated? How long does it take to deliver an intervention with fidelity? How long does it take to sustain something? So speed or time, I think, is a metric that we need to capture. And we need to capture it for implementation phases and implementation outcomes. So that's one way that I think about speed in relation to implementation outcomes as a metric. The other way that I think about it today, maybe not tomorrow, is that attaining implementation outcomes is necessary to shorten the speed of implementation or to hasten implementation. In other words, if we can ensure that our interventions are developed in ways that are acceptable, that are feasible to deliver, that are that for which there's payment in place, then I think we achieve timeliness, we achieve speed better. So in short, I'm currently thinking of speed as both a metric for implementation outcomes and as an outcome of attaining implementation outcomes. Now that probably sounds like jumbled talk, and I'm delighted to have the provocation to think through this more clearly. So I very much appreciate your concept, your question. And I think my takeaway is we need to pay more attention to speed and we need to think about it with the same urgency that we do attaining some implementation outcomes.
Thank you very much. That's certainly going to be on my mind the next few days. So thank you for that.
Mine as well. Thank you.
So Dr. Proctor, I also would like to bring in some reflections based on what you have been saying. And so this whole idea of speeding up the research pipeline is, in the end, increasing the societal value of research pipelines. And here, if we look at implantation science, and you kind of pointed to that, but I would like to have a little bit more your view on the mere fact that there should be a call for enriching the research pipeline from early on with implantation science principles, because it's not a matter of thinking about implantation science when the intervention is being developed. It's not when the first results are there. It's really trying to make sure that you have, as early as possible, some reflections on real-world implantation. Now, this is implying a new research paradigm, which needs to be not only embraced by implantation scientists, but also by clinical trialists, by funding agencies, by research policy people, but policy people in general, because in the end, talking about research waste and these numbers floating around of 85% of biomedical research which would be wasted. I mean, we are incredible with the activity that is in the biomedical research community, and then you have the implantation science. We have now the science article of Dr. Geng and you. We have recently also the JAMA, which had the editorial on implantation science. So there is some traction in the system, but thinking through what that means to really integrate implantation science very early is a new research paradigm, and embracing enrichment of what typically is being done. It asks for absolutely a new way of developing the scientific path towards discovery, towards testing, towards then, in the end, real-life implantation. So I just would like to hear a little bit from you, how you see this part, if you agree that this is the way forward, and at the same time, how we can realize that, because it's a lot of barriers. If we talk about implantation science, there are a lot of barriers on our way.
Right. I very much appreciate your observation and your thoughts, and I do agree that we need a new paradigm for how we conduct research. I think that we had two kind of traditions that, well, there were many barriers to doing research in a time-efficient way. One was kind of the siloed nature of how we defined ourselves. Many people, and this is still, these distinctions are still true. One of my dearest friends is a wet lab bench researcher, and she has plenty on her hands to develop understanding of molecular change and molecular processes. It's a far stretch to ask her to think, well, what are the implementation challenges of what you might discover? So, we can't really mess with or expect people to embrace the entire research translational process. We do need specialists who focus on specific questions in the broader research environment. But when it comes to testing interventions, I do think that we should blur the lines between intervention developers and implementation scientists. Because, and actually, after I gave a talk once about the challenges of implementation and was advocating more hybrid ones, a physician in the audience said, "Do you think we should should study sections or grant review committees insist that all tests of treatment effectiveness capture context and the requisites, the requirements to implement this intervention if it is proven effective? And, part of my answer is yes, that's a hybrid one. So why not learn everything we can about what it takes to implement while a treatment is being developed? The counter argument is that why invest those resources in collecting those data if the intervention proves to not be effective? Have we burdened an intervention trial with potential learnings about implementation before we know that the intervention is really effective? So it's very complex to begin to think about, how much we should be learning in what trial and how broad the definition of certain kinds of science are. However, I think we have to get away from the linear pipeline sequential notions of research, that first we understand basic biological mechanisms without thinking about their applicability to human use or clinical use. And then we think only about clinical use without thinking about real world use. Or we think only about implementation questions without questioning the features of the intervention or the innovation to think about repackaging. So that, by definition, the sequential pipeline notion that we're all familiar with, and that maybe we have been trained in or we've bought into, that, in my view, clearly slows the implementation process, clearly prolongs the timelines for translational science. So I think we need more iterative feedback between types of trials. And that does mean capturing as much as we can about delivery while we are still refining the intervention. What that will look like for different scientists who wear different hats, I don't know. I don't have answers to that. But yes, I think we need to challenge the traditional siloed sequential notions of first we test, then we begin to think about implementation. Then we begin to think about sustainability and begin to hardwire some of these later questions in the translational challenge into earlier phases of our research. So I don't know if that got at what you're thinking about. I would welcome your further thoughts and insights and questions about that.
So I very much appreciate your view, and I certainly would also invite other colleagues who are currently on the call to perhaps share their experiences of their country or their setting, how they tackle this, because this is something where we really can learn from each other. It is clear that once you have an idea of what the timeline or the time log is until translation, the money that is being wasted, no industry would survive if they would have this type of performance. And the societal criticism towards science is partially also linked to the fact that societal value of the money invested is not really showing. COVID, I think, is an extremely important example, and it was very interesting to see that all the attention was going, of course, in finding the vaccine. Imagine if we would have invested at the same time understanding implantation challenges.
Yes. And I thought, those of us who are implementation researchers were handed on a platter examples of barriers, facilitators, potential strategies, but mostly implementation challenges.
Absolutely. And I always cite in Switzerland, for instance, we had we had access to the vaccine, which is excellent. Policy created frameworks in order to target, as you also said, with specific policy measures to come out of the pandemic. But then in the end, if you see, and in hospitals, only 50 to 70% of the nurses were being vaccinated. This is something which could be expected because we know from the flu vaccination that nurses are very reluctant in Switzerland to get vaccinated. And here, in the end, if you look at this, it's absolutely a failure that we were not able to get to a higher percentage of vaccination. So there is, here it was kind of a clear, it was known, but nevertheless, no investment was being made, only at a later phase. And then, of course, you talked also about the mere fact of in disaster management, which COVID in the end was, the science of implantation, the science, there seems to be some background noise. So if you could mute. So if we also look at the challenge of where implantation science is today, one of the real elements, and you also talked about this, if we look at implantation strategies, this science is developing very rapidly, but it is still in early stages. I mean, there is taxonomies, but in the end, the question is, what should be your bundle in what type of situation to be kind of added to your intervention? We are not yet there. And so in that regard, the talking about, potential next pandemic that is coming up, there is a lot of reflection also in Switzerland of the lessons to be learned from the COVID pandemic. Behavioral science, implantation science is still a little bit at the side.
Yes.
So, and I think it's in other countries also. So here we can work ahead because lessons can be learned, and we know in the meantime where the major barriers were, and there have been evaluations being done of what worked, what didn't work. So it would really be interesting also to use the experience that we had to not, yes, we have a vaccine, and this vaccine is absolutely, saved us, but there is a whole bunch of work around this that could really help us to be prepared for the future.
And one thing that we're observing, which is really unfortunate, is that COVID vaccine hesitancy has spread to hesitancy for other vaccines. We've always had some vaccine resistance amongst various groups, but it seems that hesitancy has grown, fueled perhaps by the very public reporting and acknowledgement of concerns that often were counter to the evidence that we had.
Absolutely. So I would like to ask the colleagues who are online if there are any further remarks, reflections, or comments to the content which Dr. Proctor has presented, as this is your unique opportunity also to exchange with a leading lady within implantation science. I mean, what certainly I think I'm looking forward very much to your updated paper on implantation outcomes. It might also be an interesting way forward to think through when a next update of the STARI guidelines are being published, that perhaps you can work together with Dr. Pinnock to make sure that this kind of idea is also being integrated in reporting of the STARI guidelines, which are the guidelines to report implantation science evaluation studies. So there is, many opportunities for a lot of people to contribute and to make sure that our field can move forward. And so for me, I do not see any. Juliane, Mielke, is there any further chats? Oh, yes, I see Karma Deem has put her hand up. And Karma, please unmute and ask your question or say what your remark is. Introduce yourself.
Hi, good morning, everyone. Yes, I'm working from home today with a sick child, so excuse my video if it does turn on. I did have a question. This is a great presentation. I really appreciate your time today. I'm not sure what's happening to my video. My apologies. We've been having a lot of discussions. I'm at UT Health Science Center in San Antonio, Texas, and we've been talking about the linear nature of the research pipeline and how we can better do implementation science while we're doing drug discovery. And so in a meeting with colleagues, it was kind of a foreign concept for the individuals that were more in the bench science of, so what you're saying is we can do all this work and develop this treatment regimen and people won't take it. And I was like, well, it's not that grim. It's just, we don't know. And so aligning those efforts, one thing that those discussions brought to my mind is we are going to embark on a study to see what people's thoughts from the physician and the patient level are about this new medication. It's not approved, it's still in development, but trying to get a feel for what delivery mechanism would be most beneficial, what how they would view the medication in general. But as we all know, context changes, views within the population changes. So could you tell me a little bit about your thoughts on, if we're running in parallel, some of the issues that might arise from timing or following the innovation over time to make sure that they have accurate information about the system they're trying to implement into?
I really appreciate the work that you're doing and the forethought you're giving to that. You know, a colleague of mine at Washington University, or several colleagues, have worked on the uptake of the HPV vaccine for cancer prevention in early adolescence, late childhood, early adolescence. And one of the things that they've discovered is that the vaccine was designed to be given in 2 doses, and that there's a much higher uptake of the first dose, but vaccine rates fall off at the second dose. So my colleagues said, you know, what if we could study from various, I think this is akin to what you are embarking on, study over time, you know, how things are rolled out, how they are received. She said, what if we could go back to drug makers and say, you need to make this into 1 shot? She said, now I'm not a drug maker, so maybe it can't be done, but maybe it can be done. You know, I think we've seen our colleagues in HIV research, both in treatment and in refining PrEP medication, that based on the experiences in rolling out a medical intervention or a vaccine, we learn a lot about how it could be packaged. Certainly, we could learn a lot about how it can be messaged. And I've seen over time, and know that it's based on some research, the messaging to parents. Now, I know that not every country has direct-to-consumer pharmaceutical ads. And, you know, we suffer from such a plethora of those that we advertise drugs for diseases that probably don't exist. So we really overdo the direct-to-consumer television ads, radio ads about, might you have this? If you think you might, go to your doctor and ask for this medication. Well, you know, wouldn't your doctor diagnose the problem? Anyway, that's a complicated issue. But they've changed the messaging. I have seen changes in messaging around the HPV vaccine from help your child, protect your child against sexually transmitted disease. Well, most parents of 11-year-olds don't want to envision their 11-year-olds acquiring a sexually transmitted disease. So they're going to say, that's not for me. Where now the messaging is, you know, you're preparing your child for a good education, you're preparing your child to eat healthily, protect your child against cancer down the road, and talk to your doctor about the HPV vaccine. similarly, the hepatitis vaccine before kids go to college. So it's kind of a preemptive messaging, and it's couching it in terms that are more acceptable based on lessons learned from our missteps or from messages that were not accepted. So I don't know if this is relevant to what you're thinking and to your research, whether I'm responding appropriately.
Yes, I think so. And it is mainly on the dose delivery. There's a couple different steps. What I'm also picking up in your response is that, these things need to be iterative. The implementation piece of it, depending on how long the approval and trial runs, really needs to be an iterative process at certain time points in order to stay relevant. And use it also to evaluate already implemented strategies to adjust, like in that HPV cycle.
Yes.
Interesting. Thank you.
Thank you. Good luck with your child.
Thank you.
Working from home.
Excellent. So this was an extremely rich discussion, and I would like to thank again Dr. Proctor for being with us, for inspiring us, for guiding us where the future is going. We will certainly follow up your work very, very closely. For those of you who were part of this webinar, I just would like to point to the webinars that will be coming in the autumn. And you have here a webinar on implantation research for real-world change in primary care. It will be Professor Dr. Hilary Pinnock from University of Edinburgh. She is the author of the STAR guidelines, and she has an absolutely brilliant program of research around respiratory disease in primary care. Very impressive. She's a clinician, and she really lives implantation science in research, but also in the translation to her own practice. And then we will welcome in November Dr. Sherry Vogel of University of Pittsburgh and Dr. Laura Damschroeder of Ann Arbor Center for Clinical Management Research in Michigan. And they will discuss the Consolidated Framework for Implantation Research 2.0. It is a framework that is used broadly for contextual analysis. And so we really hope that you will also join us at that time. So thank you again. And we truly are grateful to Dr. Proctor and look forward also in the coming days in Switzerland to exchange with her and learn even more from her. Thank you, everybody. Have a nice further morning, noon, evening, night, because we know that all over the world you were part of this webinar. Thank you so much.